Hello friends, welcome once again to the Tutor Med channel where everything medicine is simplified. As usual, the name is Dr. Obin Frimpong and I'm glad you tuned in to this episode. In today's edition, we will look at an unmanned auscultation, a picture station exam in pediatrics or child health. And so grab your notepads and let's begin, friends. And so in this picture station, we have this. And these are the questions that follow. Question 1 says, describe this picture fully. Question number 2, what is your diagnosis? 3, what maternal condition predisposed the baby to this condition? Question number 4. List 2 other causes of this condition apart from the one mentioned in question 3 above. Question number 5. Mention 5 complications this baby is at risk of. Question number 6, and the last question, list 2 birth injuries he can have or this baby can have. And so, these are the questions. Think through them, write your answers, and let's discuss the suggested answers in the next slides. Alright, your answers ready? Let's see the suggested answers. Very good. And so let's look at question 1. Question 1 read, describe this picture fully. Now, it may not be a widely held perception, but it is my opinion that pediatricians are the most thorough and meticulous clinicians among the clinicians of the 4 major disciplines of medicine. And so the answers given must be thorough and thorough. You know, back in medical school, the suggested answers the examiners gave to some questions they asked during our revision classes gave us the impression that when answering pediatrics questions, we should take note of seemingly petty things. And so for an answer, we will say, this picture shows a crying neonate being weighed on an electronic weighing scale. The neonate weighs 4.3 kilograms. Now, I'm not saying that this is a perfect answer, but this answer tells us everything in the picture. For example, the baby is a neonate, the baby is crying, and he's being weighed on an electronic scale, and then we mention the weight in the answer. And so answers like these should be avoided. For example, this picture shows a baby with a birth weight of 4.3 kilograms. You would get a mark or some marks for that question, but not the 4 marks, because like I said, answers in pediatrics really take note of what we consider petty. They should also feature in the answer. And so, in summary, again, this picture shows a crying neonate being weighed on an electronic weighing scale, and the neonate weighs 4.3 kilograms. Very good. Now let's look at question 2. Question 2 read, what is the most likely diagnosis? And for an answer, this is a macrosomic baby, or in simple terms, macrosomia. Please, this is not the same as fetal macrosomia. as an extrauterine baby is no longer a fetus. And so, if you qualify this macrosomia as fetal, there is a problem. By definition, birth weight of 4 kilograms or more is a macrosomic baby. However, I want to point out that the American College of Obstetricians and Gynecologists support the use of 4.5 kilogram threshold for the diagnosis of macrosomia because morbidity increases sharply beyond this weight, 4.5 kilograms. Now, up-to-date documents a grading system for macrosomia. I just want to put it out here as an additional information. And so we have 3 grades from grade 1 through grade 3. And so grade 1, we have a baby with a birth weight from 4 kilograms to 4.49 kilograms. And grade 2, it is 4.5 kilograms to 4.99 kilograms. And the grade 3, it is 5 kilograms or more. And as usual, like I've been saying, whenever you have 3 categories of anything, the best thing to do is to keep the middle one in mind. Once you remember the middle one, you will be able to remember the extremes. And so if we keep grade 2 in our heads, that grade 2 macrosomia is 4.5 to 4.99, then it makes sense that less than 4.5 kilograms should be grade 1. And more than 4.99, which is 5 kilograms, should be grade 3. This grading is important because, like mentioned, the American College of Obstetricians and Gynecology have seen that morbidity increases sharply beyond grade 2 or from grade 2 or more because the weight they use there is 4.5 kilograms. And so it means that if you have a baby whose weight is 4.5 kilograms and beyond, according to ACOG, you need to be on a lookout more compared to a baby who has a grade 1 macrosomia. However, all macrosomic babies should be evaluated for the possible complications they can have. And so the summary of this question is that the diagnosis is macrosomia or macrosomic baby. And now to question 3. Question 3 says, what maternal condition predisposed the baby to this condition? Now, there are a few maternal conditions which can predispose a baby to having macrosomia, but the most common of them for an answer is maternal diabetes mellitus. Now, please endeavor to write diabetes mellitus, not maternal diabetes. Please be thorough. Maternal diabetes mellitus. Quickly, we move to question 4. The question 4 says, list 2 causes of this condition apart from the one mentioned in question 3 above. And so apart from maternal diabetes mellitus, any cause of this condition? Yes. And so for an answer, we have maternal obesity. And so that's the pre-pregnancy weight. So before the pregnancy, the mother's BMI was above 30. It can predispose a child or the baby to having macrosomia. And then we have excessive maternal gestational weight gain. And so she wasn't obese pre-gestation, but during the pregnancy, she started gaining excessive weight. That is also a predisposing factor. Then we can have post-term pregnancy. So if the pregnancy is post-term, it can also cause macrosomia, I wanted to say. Then we have other genetic syndromes like Beckwith-Wiedemann's syndrome, which is actually a syndrome made up of a macrosomic baby with a large tank known as macroglossia, and the baby with an anterior abdominal wall defect, which will result in an omphalocele, the baby with recurrent hypoglycemia, and the babies with that syndrome will also have a one-sided enlargement. One side of the body will be enlarged more than the other, and then there may be visceromegaly. It means the internal organs are also enlarged. The other syndrome is actually Soto syndrome, we have Weaver syndrome, Marshall syndrome, etc. Sometimes mothers who were born as large for gestational age, or mothers who also have a history of macrosomia, would also likely give birth to macrosomic babies. And now to question 5. Question 5 says, list 5 complications this baby is at risk of. The answer: we can have neonatal hypoglycemia, neonatal hyperbilirubinemia, neonatal hypocalcemia and hypomagnesemia. They are sometimes at risk of respiratory distress syndrome. So we will discuss these. And explain them later when we are talking about neonatal problems. But here I just want to list the answers. They are also at risk of birth injuries, sometimes meconium aspiration, and congenital anomalies. They are also at risk of perinatal birth asphyxia. And so any 5 of these answers is a correct answer. And so question 6 and the last says, list 2 birth injuries the baby can have. And the answers: we have brachial plexus injury. The most common of them is the Erb's palsy. So we will show a picture of how a patient with Erb's palsy would present in the next slide. And then sometimes you can have fractures, like the clavicular fracture or fracture of the humerus, because the baby is too big, and this usually occurs during vaginal delivery when the delivery is very difficult. So pulling the baby or putting traction on the baby's body may damage either the brachial plexus or some of the bones. And so the 2 birth injuries, or some of the birth injuries they can have, include a brachial plexus palsy. When the upper roots are damaged, it results in Erb's palsy. And then when the lower roots are damaged, it results in Klumpke's palsy. But sometimes you can have a total brachial plexus palsy. Please remember from anatomy that the roots, or the nerve roots which make up the brachial plexus, is C5, C6, C7, C8, and then C1. And so the C5, C6 makes the upper, and then the C8, C1 makes the lower. So I'm saying that when you have a damage to the nerve root C5, C6, and a bit of the C7, you may have Erb's palsy. And we'll show a picture of Erb's palsy in the next slide. Very good. And so on this slide, we want to show a picture of a patient or a baby with Erb's palsy. Now, usually when the baby is stimulated or when the baby is active, the baby is able to move all 4 limbs. We should suspect Erb's palsy, especially when we have a background information that the baby is big for gestational age and the baby is not moving all 4 limbs simultaneously. One limb is kind of stationary whilst all the other limbs are moving. Whenever that happens, we should suspect an Erb's palsy or an injury, not Erb's palsy, an injury, which could be a fracture or a nerve injury. Now, in Erb's palsy, the baby would have an internal rotation of the arm, like you can see. How do I know the baby has internally rotated the arm? Because the arm, if you look at the arm on the right arm is pronated. It means that the baby has internally rotated it. It is not supine, but in a prone position. And then the baby has adducted the arm. So the arm is now close to the trunk, and you can see the waiter's tip. The hand shows the waiter's tip. When the waiter is taking money from a customer for helping him or her, that sign they do is called a waiter's tip. So this baby has an internal rotation of the arm, adduction of the affected arm, and then the waiter's tip. And then more importantly, if we have a background information that this baby is a large for gestational age baby who was delivered vaginally, and the baby is not moving all 4 limbs simultaneously. One limb is static. We should suspect an injury. And if you see this picture or this position, the internal rotation of the arm, the adduction of the arm, and the weighted step, you should be thinking about Erb's palsy, which is an upper brachial plexus injury. And so thank you for watching this episode. Thank you for liking and sharing this video. Thank you for subscribing. See you in our next video, and until then, arrivederci. Bye.